Hello, I'm Josh Grew, a researcher at the think tank Living and Dying Well, which provides research and analysis surrounding the end-of-life debate. And this is the second of a series of short interviews on the topic of assisted dying. It's great to be joined by Professor Kevin Yuill, Professor of American History at the University of Sunderland. His research focuses on the relationship between the citizen and the state, and he's written on the ethics of suicide, euthanasia, and assisted dying. Thank you for your time, Dr. Yuill.
Thanks for having me.
So, to dive straight in, what social impacts, if any, do you think that an assisted dying law would make in the UK?
Well, I think it would erode moral equality. And what I mean by that is that at the moment, right now, it is equally wicked to kill an 86-year-old who does not value their life as it is to kill a 24-year-old who does value their life. And with that is expressed in our homicide laws, but also at the moment in our suicide laws. We try and prevent the suicides of all rather than simply saying this group of people, we try and strenuously to prevent your suicide, and this group of people, we actually encourage you to kill yourself. So I think that's my biggest overall concern with the social impact, what I think the social impact would be of legalization in Britain. So a very good example of that is something I've written about just yesterday, in fact, which was the Graham Mansfield case in the UK, which was, of course, the gentleman who slit his wife's throat at her request, apparently. I mean, we obviously, he was convicted of manslaughter by the jury, which meant they believed that he was doing it for compassionate reasons. However, the implications of that are that it's somehow okay to slit the throat of somebody who is terminally ill, but it's not okay to slit the throat of anybody else. And I think that's a sort of illustration of the way it might be regarded if we legalize assisted dying in the UK. By the way, I refer to it as assisted suicide because I think the proposals in the UK are actually fairly specific and they don't involve euthanasia. And I think it's much more accurate to actually say assisted suicide. I think another aspect of another social impact that legalization would have is to create demands in groups which would not be included in the initial right to die, which in the proposals that I've seen in this country are based on the Oregon legislation, which is assisted suicide, which means the person actually has to accomplish the act themselves. And that is legal. It's also meant to be restricted to people with 6 months to live or less. And what I think it would do is create a demand for that service. If you start defining suicide as medical treatment or assisted suicide as a medical treatment, how can you deny it to anybody else? How can you deny it to children, for instance? How can you deny it to people who are suffering from mental health problems? So I think that's also very much on the cards, because if you look at Canada, which legalized euthanasia and assisted suicide in 2016, in March 2023, they will be extending it to the mentally ill. So those would be my initial responses of what social impacts would occur if it was to be legalized.
Thank you for that. And just on that, you mentioned some potential consequences. And my next question is, are there safeguards that could be implemented that would be kind of practicable? Are there possible safeguards that could be put in place? Because we've seen that in other jurisdictions where the law was originally had original limits, and those limits have gradually been expanded. So, in your view, are safeguards possible and practicable?
I don't think that they are. I think the problem is that we look at these cases, and this is the way that, for instance, Dignity in Dying and the other pro-euthanasia and assisted suicide organizations actually use examples of people who are very, very ill, who are suffering at the very end of life. And they use this sort of emotional aspect to get the legislation passed throughout. Now, safeguards you could argue, for instance, that safeguards have worked in Oregon in the sense that they haven't been extended very much. And as it happens, they have been extended in that you no longer have to have a waiting period in particular cases. That has been adjusted. However, in the United States, 4/5 of the states have yet to actually enact assisted dying legislation. And so therefore, there's a sense that you want to push them past the line, and therefore you don't want to extend it. Whereas in each country, each nation where it has been passed, it has been extended. And that includes Colombia, which just extended it a little while ago. But certainly, even in the Netherlands, it was first passed on the basis of the Postma case, which was a terrible situation, as you know, most of these situations are, whereby a woman and her husband, called Postma, eventually killed her mother, who was suffering from advanced problems, a disease that was eating away at her. And of course, she had fewer than 6 months to live. But as we know, it's passed in the Netherlands into all sorts of other different categories. And in recent times, we've had a woman with tinnitus who's suffering nothing other than tinnitus was granted euthanasia for unbearable suffering. So it's anything with unbearable suffering now. And this is the problem. If you sort of say to people, well, you can have it if you're suffering unbearably, who actually decides who's suffering unbearably? It is only the patient that can decide that. There's not a doctor who can diagnose unbearable suffering. And it would be patronizing to say, no, you're not suffering enough and you are suffering enough. So I think that's an inherent weakness in any of the safeguards, is that they are discriminatory against people who are suffering unbearably. So you inevitably find a weight of people, excuse me, saying, but I'm suffering unbearably. And this is what's happened in Canada. And in Canada, we've even had a couple of cases where people are suffering unbearably from poverty, and that these are considered for euthanasia. So I think that the inherent problem is, where do you draw the line? That is where, in fact, that's what undermines all safeguards, is that one question: where do you draw the line? And there's no fair place to draw the line at all. So I think that's what undermines safeguards.
A key tenet of the debate is around autonomy and choice. How would you respond to claims that as autonomous individuals, we should have a right to die in the same way that we have a right to do make other life-affecting choices?
Well, I mean, everybody does have a right to die. In fact, there's nobody alive on earth who is a competent adult who cannot eventuate their own death, who cannot cause their own death. And this is very much illustrated by the case of Tony Nicholson, who was a campaigner for euthanasia and assisted dying. He was paralyzed and could only flicker his eyelid. That was the only way that he was able to communicate. And he managed to cause his own death by refusing food and drink. It is possible if you are determined to do it. The question is, should we make that easier? Should we assist certain people and stop other people from killing themselves, or attempt to stop other people from killing themselves? Because if they are determined, they will do it. So first of all, you do already have the right to die. Second of all, it's a bizarre right, because how can you sort of say, I have a right to die in a manner of my own choosing? Does that mean that, for instance, a woman could demand to have her throat slit by her husband? I'm not sure that's a good way of that's a practicable idea of how to actually set things up. Can I insist that I die by firing squad? I don't think I probably can. So this is very specific circumstances, and these kind of phrases that are trotted out so easily by organizations like Dignity and Dying, we have to really look into the meaning of these phrases and see that they don't actually mean that much. It's also a bizarre idea that you have a right to die, both because, as I said, you have it already, but also because we don't have a right to be born whenever we want. We don't, the way you enter and leave life does not, you haven't got control of those particular circumstances. If I had a right to die in circumstances of my own choosing, I would choose probably past 100. That may not actually work. And so I think that's a kind of bizarre idea, the right to life. I don't think you have, the right to die. I don't agree that you have a right to life, as in, how are you going to exercise that if you walk out your door and you're hit by a bus? Your right to life means very little in those kind of circumstances, nor do you have a right to die in the way I've just described. What they are asking, in fact, is not for a right to die. It's a right to be helped to die. It's a right to outsource your suicidal wishes, I suppose. It's a right for somebody else to take part in your killing and to be sanctioned by doctors, who are, of course, the new high priests of in our medicalized world. We await their approval. So I don't think that the right to die is a particular meaningful one, and I think it's one that we can very profitably interrogate.
And finally, how can we be compassionate to those who are suffering and who do not wish to be a burden on families? That's been another key part of the debate, is around compassion in suffering. And so what would you say to those who say that passing legislation on this is about facilitating compassion?
Well, first of all, I don't think that legislation actually can facilitate compassion. We have to feel compassion as individuals. So that would be first thing. You can't simply pass a law that creates compassion in individuals. It doesn't work. But I think the key thing we can do is respond to people's suicidal wishes, like we do the suicide, if we get the chance, like somebody who expresses suicidal wishes who is not terminally ill, which is to say, why do you actually want to die, and what are you fearing? What do you think that actually can happen? And most people can actually be, comforted by that sort of approach, even and this is as Elizabeth Kubler-Ross, who was the pioneering author of On Death and Dying, and really popularized the whole discussion on dying in the 1960s and 70s. And she was opposed to assisted dying because she said, you are cutting off part of somebody's life. That's not a compassionate response. A compassionate response is to ask why somebody wants to cut out part of their life. And as my colleague in the Netherlands, Professor Theo Boer, makes the point, he said, this is really about fear of living rather than fear of a bad death. It's fear of a bad life at the very end, rather than the fear of a bad death. It's not about pain. We do know that pain doesn't come up in the top 5 reasons why people in Oregon or the Netherlands actually opt for euthanasia or assisted suicide. So it's not pain. And all of the other conditions that are causing somebody to be suicidal can be adjusted, can be dealt with in a different way other than agreeing to kill them. So I think you can be compassionate in these situations. But most deaths, as I say, fewer than 1% of deaths by dignity and dying's estimation are actually bad deaths. So we can look forward to much more comfortable deaths in the future. And I think we can put our faith in hospice care, which I think is a great answer for end-of-life care.
Thank you so much, Kevin. Some really interesting thoughts that you shared there. Do watch out for the next interview in the series. And in the meantime, head to the Living and Dying Well website at livinganddyingwell.org.uk to find more research and information. And thank you for listening.